Reagan Robertson here with Productive Dentist Academy. Get ready to join your favorite podcast hosts, Dr. Bruce B. Baird, Victoria Peterson, Dr. Chad Johnson, and myself, Reagan Robertson, at the nation's #1 dental business course that guarantees practice growth. That's right. Full immersion CE, so you can consistently produce more and align your team for results without compromising excellent patient care. Productive Dentist Academy has a special running this month that you can activate immediately. It's called the PDA Productivity Bundle. And we put this together so that you could attend this workshop, which is happening September 22nd to the 24th in Frisco, Texas at the Hyatt Regency, along with tools to make sure that not only are you getting great education on how to increase your productivity, how to communicate better with your team and your patients, increase your case acceptance, authentic market practice, and more, you also get a 2-hour business advisory session before the workshop to really get clear on what matters to you most so that you can be set up for success at the workshop. And following the workshop, you get 12 months access to PDA on demand. That is the entire productivity workshop on demand for you to make sure that you are doing everything you can in your power to soak up all of that CE and implement it come Monday morning, the next month, and the next month, and the next month for 12 months down the line. Registration is now open. The tuition cost is $2,195, which is ridiculous because it's regularly $5,528 for the productivity workshop attendance, 2-hour business advisory session, and 12 months access to PDA on demand. Hop on over right now to www.productivedentist.com/workshop to grab your registration today. Again, that is www.productivedentist.com/workshop. If you cannot wait and you have to have it right now, email Brent, B-R-E-N-T, at productivedentist.com. That's Brent, B-R-E-N-T, at productivedentist.com, and we will save you a seat. I look forward to seeing you there. I have a question for you. How would you feel if you were doing everything you'd been taught to do? Your patient was doing everything you told them to, and despite all of your combined efforts, your patient continued to suffer from disease. The reality is this does happen quite a bit, and it can be really frustrating. Dr. Chad and I believe you don't deserve to experience this. That's why we've invited renowned dentist Dr. Kim Kutsch, founder of CariFree, on Everyday Practices. Dr. Kutsch's lifelong passion has been the prevention of dental caries. He has written over 100 articles on caries prevention and is a revolutionary advocate for patient health. When I think of the Super Bowl, this is Dr. Kim Kutsch and what it means for dentistry. He is at the top of his game, and it's only getting better. In the first part of this 2-part series, we're going to discuss why it's important as dentists to be courageous and challenge the status quo as advocates for their patients' health. Let's dive in.
Yeah, so I liked where we were going with that. With there's a lot to be done. There's a lot more to be done as far as the patient education goes. I think that's really critical. It's something that we just can't take it for granted, but in the day-to-day business, we sure can have a tendency to.
Yeah. Well, we get so focused on, we're wearing loops, right? And we get focused on the individual tooth surface that we're trying to restore. And so our attention and our focus just goes to that. And we really need to step back and look at the person as a whole. And then we really need to go upstream and go, what caused that? Right. And let's talk about that. And I think that's where, we can most help our patients understand, what's causing their diseases in their mouth. And besides just treating the results of those diseases, and it's also the work that we need to do with the profession to help understand that we need to go there, right? And rather than just focus on, new restorative materials and cements and, preparation design or what have you, that we really need to step back if we're going to be successful at treating these diseases and really having better outcomes for patients. That's really a focus that we have to go up and upstream and look at the cause. And I think that's where we as a profession need to go. And that's where really we, you and I and Chad really can help our profession itself, in terms of just making them aware of that, what's going on in that transition.
So your clinical career then started right out of school in '79 from Oregon, is that right?
Yep,
Okay.
that's correct.
General dentistry.
General dentistry, I did it all,
How are you still doing clinical?
Nope, I gave up clinical. It'll be actually 3 years ago.
Okay.
On the 26th of June, it will be 3 years.
Yes.
I took the summer off and not really intending to retire from clinical practice, and the practice didn't really need me to come back. And I thought, maybe this is the right opportunity for me to step back and then focus on, what I'm doing in the world of, dental caries.
What impeccable timing! Impeccable timing for the world's demise.
Yeah, I mean, I had no clue, but it just, for me, and physically, my neck and back, I was out of pain, during the summer, for having 3-4 months off, and I thought, I really don't. My body was telling me it's time.
So, I mean, that would be what, a day or two short of a 40-year career.
Yeah, exactly.
I mean, so I'm just trying to put it in perspective. You, for 40 years, did clinical dentistry. And at what point did CariFree come about in your mind? Not the product, but like the solution, and then I'm going to work backwards, just like you were talking about. I want to talk about the solution, then work back and ask, what was the frustration? But first, the solution, when did that come about?
Actually, Chad, I have to look back to my dental school experience is really where the roots of all of that started. I was the patient, or the student, rather, I should say, that my parents always taught me to challenge everything. Strategically, think for yourself, challenge everything. If somebody says, well, that we do it that way because that's how we've always done it, that's like the worst possible answer.
Absolutely.
And you should challenge that. And so I did. Now,
welcome to the contrarian club. I love it.
Right. And dental school was not really a good place for you to behave that well, right?
Absolutely not.
They're all about conformity, right?
Yes.
And I mean, I get that now, but I guess my entire career, I was always looking for, there's got to be a better way, right?
Yes.
There's got to be, if we've been doing it this way for 60 years, there has to be something out there that's better than today, right? And so I started by looking at materials, and I quit using amalgam in 1983. I had mine removed, and it was such an amazing experience for me. Suddenly my teeth were not sensitive. I just I looked in the mirror and I thought, I couldn't do this. I couldn't continue to put these in, I wouldn't have these in my mouth again. And like, how can I put those in somebody else's mouth?
Now that right there is an Oregonian.
Yeah. And that wasn't a particularly good time to stop using amalgam, because our alternative materials weren't all that wonderful. But I think that gives you kind of an insight into, my process, as a professional, as a dentist. And I got involved in lasers in 1989. And so I was coming about it from a mechanical restorative, because that's how we're trained, really. I was looking at it from a materials, technology. I was looking at how do we improve the outcomes for patients, this way. And
I do think it's tough because there's pragmatism involved. It's just like, that's neat to daydream about one day when we can all have a magic mouth rinse. But until then, you've got a cavity in op 2 that needs filled,
Oh yeah. So, I'm walking that reality of like, I'm working 3.5 days a week, seeing a lot of patients and filling a lot of holes in teeth. And I got involved in lasers, and then that led to, microscopic air abrasion and, restorative materials and techniques and microscopes and all of that in the early 90s. And I built a large company, Creative, that I sold to Welch Allen in 1998. And I guess at that point, I was thinking that by diagnosing these lesions earlier, treating them earlier, like this was going to be the solution. And it wasn't, right? And it was really, I was lecturing in Australia. I spent a month in Australia teaching in like August of 2000. And I shared the podium with Rella Christensen down there a couple of times. But one of the places I ended up was in Adelaide, University of Adelaide, and he and Noah was there running a research center. And Ian really opened my mind to the thought that dental caries is a disease. And, we're not going to drill and fill our way out of this disease. We need to look at it and treat it like a disease and figure out what's causing the disease. And for me, that was like an epiphany. And I came back, and just by chance, the next meeting I spoke at was like in the Cayman Islands, and Doug Young was on the podium right after I was. And Doug, who was at UOP, he was a student of John Featherstone's at UCSF, the whole caries risk management program. Doug was really a pioneer in that. And I mean, I picked his brain like right after that. And that's really where CariFree started. I mean, Doug and I sat down and I said, hey, I get it. I finally, 20 years into my career, I get it. I want my patients to stop. I've done everything that I was trained. My patients are doing everything I'm requesting them to do, and they're still getting cavities. And so Mike, it took me, I feel kind of like stupid that it took me 20 years to realize this doesn't work, right?
Well, so I've seen, I've read both the Why Me and Balance books. When were those written? Was that more like a 2010, 2012 era?
Yeah, so the Balance book was written in 2012.
Yes.
And that's a funny story. And the Why Me book was written in 2020, and I think we got it on the market, published, printed, in print like 2021. So it's been out about a year.
And that's more patient-centric.
Yeah, and I wrote the first one, Balance, with the help of a couple of my teammates. But I primarily wrote the first book, and I thought I was making it patient-centered, right? And I was just too deep in the forest.
Well, listen, as soon as you say pH,
yeah, I
you're
mean,
done.
And it was way too scientific.
Of course, I think with patients, as soon as you say acid, they go, all right, and then you go pH, and they go, nope. Yeah. And if you even go logarithmic, they're like, right?
Yeah, and if you say mutant streptococci, like their eyes glaze over, right?
Right.
And so I wrote that book in 2012, and we printed it, and we had to print like 10,000 copies, right, to get a reasonable price on this book. So I was leaving for a 5-week stint. Dana and I were traveling abroad. I was doing some teaching, and then I was headed to Africa. And my son-in-law was with me at the time, and I told Bob, it's like, we got these pallets of books, and I had this vision of, when I die, my kids will have these 2 pallets of books in my garage, and they'll go, what do we do with these things, right? And I came back 5 weeks later, and they were all sold out. And I said, Bob, say that again, because I thought I just heard you say they were also, yeah. And he always called me boss. Yeah, boss. And we had to order 10,000 more. And I'm like, what? And that book took off. But however, it ended up being used in dental hygiene programs in dental schools. It's for second-year students for dental caries. And so I realized that I had missed the mark for my goal, because I really wanted a resource I could hand to a patient and just say, read this, dog ear it, mark it up, and bring it back, and let's talk about it. When you see something in there that you relate to, or you think this might be me, bring it back and let's talk about that. And so then I hired a professional writer to help me. I gave her all of my materials, and I wrote several of the chapters, and then she helped me really reformat the Why Me book really for patients. And because she was not a dental professional, and so she looked at it from a patient standpoint and trying to understand it herself and format it. And really, it's won 3 awards. I'm so happy with that book, just from the standpoint that I finally hit the mark in terms of, now you've got a book you can hand to a patient and say, hey, read this, and then come back and let's sit down and talk about this, because we're going to figure out what's causing your cavities, because the answer is in here somewhere.
Well, right? To back it up, I even wonder if you get challenged passively from dentists. I'm 42. So let's say dentists about my age and older, that they give lip service to it being a disease. But the first time that you heard it and you said that you had an epiphany, my feeling though is that most people are crossing their arms and saying, yeah, I mean, kind of, but not really. And so like, there's actually I think a dentist disbelief in that maxim as well, that, you know, that this is indeed, I mean, when I explain it to my patients, I say, listen, your teeth are a neighborhood of houses, the way I see it. And these neighborhood of houses, if one house is on fire, and that fire being a cavity, you don't just get a hole in your mouth, it's bacteria, and that bacteria can spread like wildfire with the wind, and your spit is the wind and it carries it everywhere. So if one tooth laughs at the other tooth in the neighborhood, like, haha, you're on fire, you better watch out, because it might spread, because the more teeth that are on fire, the more likely you're going to get burned too. And you better not be laughing about it.
Yeah. You know, that's a great, I like that analogy, Ted. That's great. In fact, I might use that sometime.
Go for it.
But, you know, it really goes back to our
Balance
dental.
2.0.
Yeah, it really goes back to our dental school experience. You know, we're on the, you know, at Oregon, I was like on the microbiology was like on the 5th floor, and we're trained all about all the bacteria. And we had all of the classes, and, you know, we, you know, cultured our own mouth, and we did all these things. And so you get this idea, you get this understanding that dental caries is in those days, a bacterial, you know, caused disease. And then you get down to the clinic floor, and they put a drill in your hand and go, here, go start drilling.
That's when pragmatism wins. It's just like, yeah, that's neat and all, but we've got teeth to fix. It's like if you were on a battlefield and it's like, that's neat that you're learning about diabetes. We've got feet to chop off. We've got arms to reattach. You know, there's bigger things going on. And so then pragmatism wins.
Yeah. And I think, you know, so I think, Chad, going forward, certainly I think at this point in time, I think the pandemic is changing healthcare.
Yes.
From the standpoint of people are suddenly, I mean, they're testing themselves at home. They're much more aware of, you know, this virus generated disease, and asking more questions, and more comfortable with the whole concept of, you know, you got this virus, but it's causing this whole disease, and it's, you know, transmissible, and we're testing, and we're doing all this stuff. And I think it's really got people more focused on their own health. You know, I mean, we've all had to, right? And the risk associated with, well, I'm going to go out to a restaurant tonight. You know, there's a risk involved. I might come home with COVID, or I'm going to get on an airplane, and, you know, or I'm going to go to church, or I'm going to do whatever, or I'm sending my kids to school. There's a risk, right? And so I think when we start talking about risk association with like oral diseases, people are like, It's more like they're ready to hear the message, I think, because they've been kind of preconditioned by our experience with the pandemic. Dentists, on the other hand, I think the greatest challenge for us is in our profession is trying to change the mindset of put the drill down, and instead of asking how many cavities they have, ask why do they have cavities. Right. And if we can get that mindset to change, and it's changing slowly, Chad, like in the schools, although even in the schools now where they're trying to teach, I mean, it's their intent to teach it that way, it's still hard to get around that pragmatism at the end of the day.
I think there's the best intentions, but then pragmatism wins, because then you get out and it's like, well, I've got bills to pay. And how do you pay bills? By diagnosing caries? And by fixing caries.
Yeah, exactly. Right. And I think a lot of the students coming out of school today have a tremendous amount of debt, right? Student debt. And they end up in a lot of corporate practices, and which quite frankly are, you know, just driven by bottom line numbers. And that's where that pragmatism wins. It's like, yeah, it'd be nice to go upstream and let's talk about what's causing their cavities. But right now, this person needs like 22 restorations and 2 implants and whatever. And I'm busy and I've got debts to pay. And
they don't care about epidemiology.
Yeah. Well, I mean, at that point in time, you just don't. And the infrastructure isn't in there to support that as well, right? Because it takes time to educate it takes time, whether it's the hygienist or the assistant, or the dentist himself, you know, creating that infrastructure within your practice to really have time to talk about real prevention. It changes your infrastructure. You can't do it in a 1-hour hygiene appointment. We've already crammed 8 hours worth of stuff into that 1-hour appointment. That has to change. That's ridiculous. Hygienists, I don't know how they do what they do in an hour. It's crazy. That whole traditional structure for the hygiene recare appointment really needs to be patient-based. Like some people might only need 20 minutes, and some people need like 2 hours just for, their twice a year recare, right?
Right.
I have a question. What
Yeah.
would an ideal appointment from your perspective look like for the hygienist?
Well, they'd have to collect all their data, right? So you have to like review the medical. I mean, you start looking at the list of tasks in that hour appointment we're asking people to accomplish, right? You greet and seat the patient. You got to review the medical history, and that takes some time. If you've got risk assessment forms, you need to look at and do those. If you're doing any bacterial testing, you need to do that right away. Then you're maybe taking radiographs. Then you're charting. You're doing perio probing, right? Then somewhere in there, the dentist comes in for an exam, does a recare exam, which could last from 3 minutes to like 20 minutes, depending upon the complexity of what's going on. And then the hygienist needs to figure out, and the dentist need to figure out, well, is this a single appointment cleaning, or do we need to spend 2 hours? Is there root planing involved? Do they have periodontal? Is there occlusal disease? Is all of this going on? And then you have to clean the teeth. I mean, patients expect that, right?
And polish, of course.
And polish, right? And
because they expect that.
Exactly. And fluoride treatment. And then at the very end, if there's any time left over, we can talk about, what's causing your problem, right? And there just isn't any time left over, right? I mean, they barely get all that stuff done in the first place, right?
Reagan, that's a super question. So like, Dr. Kutsch, in your practice, the value proposition, that's the difficulty, like that we have to accept it, then the patient has to accept it. Were you fee for service?
Yeah.
Okay, this only makes sense. I was explaining to my hygienist 2 days ago at our monthly meeting, I said, you guys understand if we're charging $60 for an exam and I'm trying to shoot for 1,500 an hour production, that's 2.5 minutes of exam time before that is make or break. So when I spend 10 minutes, we've given them 4 times the value of what they paid for that, for that 10 minutes. And just to explain it in a different way. And they're like, huh. And so, but like we're not only doing that, but at the end, somehow we're going to be looking at the occlusion, and somehow we're supposed to do a cancer screening too, and make sure that, it goes on and on.
Yeah, I mean, it just goes on and on. And so it's like, to be able to do it and do it well, there are some patients you can do that in an hour, right?
Sure.
But a lot of people require more than that. And if you're going to spend any time in education, and that's when you almost need another person in the practice to do like wellness coaching, like to be able to go sit and look at your look at the patient situation, hand them like a book, like Why Me?
Like a patient liaison.
Yeah. And then have that person who's actually has some coaching experience, have another 30-minute appointment just alone with them one-on-one to go sit down and go through that, and really then share those results and the patient's desires, or their what they want to do with the team, and that includes the hygienist and the doctor and whoever. I mean, that I've tried to set that was where I was headed. That was my goal when I left clinical practice. In fact, I'd spent 2 years on a wellness coaching program with Verosia Knight. Oh man, probably back in 2010, 10, 11, and 12, and learned the language, the coaching language, because it's really, it's a learned skill as well. But I think that's kind of where we have to go. But at the end of the day, Chad, the real elephant in the room here for me over the last 20 years teaching, and it's still there when I teach in dental meetings, and I have a lot of dentists. A hygienists get it faster than the dentists do. I mean, because for them, it's like they're in the trenches, and their primary concern is not the $1,500 an hour. Their primary concern is patient care, right?
Yes.
I mean, that's
and they're invested for 1 full hour with that patient.
Absolutely.
And they don't have to unlearn the pragmatism.
They're the face of the practice. They are the patient's advocate, right? And appropriately so. But for the dentist, the elephant in the room is like, well, if this really worked and my patients stopped getting cavities, and they've got the pragmatic mindset of like, I need to produce $1,500 an hour, and I'm not getting paid to do this, or I'm not getting paid very well to do this.
So I'm going to say it out loud. There's a conflict of interest, an ethical conflict of interest.
I think you could phrase it that way.
Yeah, I mean, I hate to say it, but yes.
Right. But here's the thing. And this was maybe for me a couple of years into this. So like 2000, I started doing this in 2000, right? And so 2002, 3, somewhere in that, and I had a hard time just even getting this into my hygiene team, right? Just to even fill out a risk assessment form. And I mean, it was a real challenge to just integrate that. And nobody knew how to do it because nobody had done it. I mean, I was trying to do something nobody else had done before that could go, oh, here's how you do that. And we had these complicated risk assessment forms and decision trees. And I look back and laugh at the materials.
They still are complicated.
Yeah. Well, I like to think that the form I finally developed over 20 years is I like to think of it as simple, but it is a change in mindset. But the elephant in the room is once, and Bob Barkley said this back in the 70s, and I was in dental school, a young dentist.
Your pet spayed and neutered.
Yeah, I didn't.
Oh no, wait, that was wrong, Bob Barker.
Yeah. So
Bob
he
Barkley.
He said, patients don't start buying real dentistry until they stop getting cavities. And I'm like, well, that didn't really make sense to me, right? And I'm like, what's that about? And of course, then he died in a plane crash in 77. And he was a brilliant man. Anyway, now I get that, right? And I think that's the message here, because by going upstream, getting patients decay free, suddenly the house was on fire. The house is no longer on fire. And now they want to remodel the entire thing. Okay. Right. And it was this little lady, she needed a 5-unit bridge. She was missing 29, 30, and 31. And I mean, she didn't have anything to chew on her right side. Right. And she was probably in her late 70s, and she'd been with me for like 20 years. And every 6 months I'd propose a bridge. Right. Or let's talk about options and alternatives. No, Dr. Kutsch, I'm fine. I don't need that. I'm doing great. But she'd always have decay. And I got her, she took the leap to go through this caries risk assessment. And we figured out what was causing her cavities. And 2 years later, like had been decay free for like 2 years. And I had quit even bringing up the bridge. Cause I mean, even me after like 20 years, I mean, I don't like rejection that well. Right. And, I didn't even bring it up. And she looked at me at the end of the appointment and said, Dr. Kutsch, is it too late for me to get that 5-unit bridge? And I looked at her and I was like, whoa. Now you're in your 80s, right? Why you're getting by with that? Why would you possibly want that bridge now? I mean, that was my response, because I was just, it's like, whoa, what? Why are you possibly interested in that now? And she looked at me and she said, because now I know that it's going to last.
Very cool.
And that was like the light went on for me. And it was just suddenly I heard Bob Barkley's voice and I'm like, I get it. And how many times have you heard patients say, I'm never having a root canal again? Every one of those I ever had failed. Right. Never wasting $1,000 again on a crown. Every one of those I ever had failed. I'm never doing this again. I'm never doing that again. And once they get to the point where they've been decay free for a while and they feel in control of their health and they have the confidence, suddenly it's like, ooh, I mean, literally I had patients like, oh, I want 20 veneers. I want this, I want that. And I was like, I was thinking I was putting myself out of business. Honestly, in 2000, I would have patients say, Doc, if this really works, aren't you kind of like putting yourself out of business? And I'd laugh and I go, hi, yep, that's my plan. And I want to spend more time fishing. So this is what we're working on.
Yes.
And, and I honestly thought that I was going to have less to do. And in the 20 years, my practice grew so much, and I did more large restorative cases. Of course, I went through the Kutsch continuum, which I think gave me the skill and confidence to approach those complex cases and treat them with predictable outcomes. I had that degree of confidence and experience at that point then, but I did more large restorative cases after my patients quit getting cavities than I'd done in my career. And so I made more money as a result of doing the caries risk assessment than I did before I was drilling and filling.
So when did you go through Kutsch?
I started Kutsch like in 2000, 2001.
Is that when you had first met him? I mean, is that how the relationship?
I'd met John back in the late 90s.
Okay.
And I wanted to go through his program. Like I wanted to go through it, and I didn't have time. I sold my first company to Welch Allen. They had an exclusive with Patterson. They had me on the road for like 2 years. I was helping them in the transition, and in addition, and I'd taken a sabbatical out of my practice for 2 years to do that, and I just didn't have time. And I told Dana, as soon as I get back to practice, I just want you to know I'm going to COIS. And I sat in that first program, treatment planning 1, with John, and he started talking about risk assessment. At that point in time, I was all about risk assessment, right? I was trying to sort my way through that, landscape. And John's talking about it, and I thought, I went up to John, I said, and he knew, and I knew John, right? And I said, I just found my home, right? Like I just found where I belong. And here's my peers. And I've been there ever since. And I think I completed it like in 2005. And, it's a lot of material. What people don't understand is it's like a postgraduate program in dentistry, and it's a lot of I mean, it's like a lot of material.
I've gone to the first 4 classes. So
and it's hard to come back and take all that information and implement it.
What to do.
Yeah, what to do. I mean, just it changes all your systems in your practice. And so it takes a tremendous amount of effort to implement, but just the knowledge base that you have on occlusal disease and periodontal disease and the periodontal interface, and that changes your whole perspective, I think, as you sit down with patients who have complex oral issues, right? And it opens up a much larger option for treat. Chad, you have more resources available to the patient because of your knowledge now, right?
Yeah.
Right. So you can offer them things that maybe you weren't aware of, you were capable of or able to do before. So,
well, one word, deprogrammer. I mean, come on.
Yeah. Oh gosh. I mean, when I took the first occlusion class, I have to laugh about this, but for the first time, I thought, here's somebody this is the first person I've met in dentistry that actually understands occlusion. Literally,
Yes.
it was 25 years into my career, and I'm like, this is the first person that gets it.
And
right?
Did you notice he was a colleague in questioning the dogma?
Oh, totally.
Yeah.
John, I mean, I think that's maybe why John and I get along so well. We're such great friends. But yeah, I mean,
you'll get a kick out of this. Even in dental school, I remember we were learning. So this is 01 to 05, and learning. You're supposed to have them pre-med for their joints, and I thought to myself, like, do we know that, or is this just a PR thing? Like, is it our fancy word? Is it medical legal? But right. I just remember going, really? Is this backed by anything, or is this just kind of anecdotal? And then later on we go, oh yeah, you don't need to do it after a couple of years. And I'm like, why 2 years? Well, well, if you have a stent of this particular kind, you don't need to do it. And I was like, I knew it. I knew this was all just a farce. It right. just seemed, right. it seems like it makes sense, but then you go, but does it?
Yeah. I mean, Chad, for me in dental school, this is like even maybe first year we starting to, you got the articulator and you got your models mounted, and they're starting to talk about lateral excursive movements. And, I'm doing this on the model. I mean, you got to have this canine guidance because you got to be able to separate the teeth as you go into lateral excursion. And I'm doing this, and I do it in my own mouth. And I'm like, and I go to my instructor and I go, I'm really sure I've never done that in my entire life, right? This inside out chewing, to me, I'm just like, this doesn't make any sense at all. And again, it was a challenging mindset. But it's like, I've never done that ever.
John blew my mind when he said that kind of chewing doesn't happen. I'm like, what? And then he's like, well, let me show you how. And I was like, huh? We're 10 hours into that day, that I'm like,
right? Chewing is not inside out, it's outside in, right? And it's like all of the occlusal theories and design and everything is all about, inside, has been forever, it's inside out chewing.
How did that standard even get started? If it's completely inaccurate, how did it get started and then set as the standard of what we teach?
You don't question the orthognathic people. That's, Rule number
To be honest,
one.
Reagan, to be honest with you, I have no clue how it got started. All I know is it was probably 80 years old by the time it got to me and when I was in school. And I was like, no, that doesn't even make sense. And so, and as a result of that, I don't think anybody really understands occlusion, to be honest with you. You have some schools of thought, and it's like, yeah, okay, so if you treat them that way, that will work with about 20% of the patients. And as long as you treat everybody that way, that's, you can handpick the 20% that'll be successful for. But to really just be able to totally understand occlusion, I mean, John is the first person I think that really got it. And once I understood that, it was like, oh, well, then suddenly if you, let me put it this way, if you put 20 veneers on somebody and you have to put them in a night guard appliance to protect the veneers, you don't know what the hell you're doing, right? And there are places that teach that, right? It's like, in my mind, the porcelain's in the wrong place, right? And so if it's in the way they're going to break it at night, they're going to break it during the day, and you haven't done a good job diagnosing how these people function. So I don't know. We could get into that topic for quite a while, but anyway, Chad, my point was, I really going to COIS really was life-changing for me because it really cemented a lot of my beliefs in terms of, and particularly, just risk assessment-based care. And then I kind of grew into be John's scientific advisor for dental caries because, he asked me years ago, he said, well, Ken, would you review some articles on dental caries and, and send them to me? And I'm like, well, yeah, I do that anyway. Like I'm reading everything I can get my hands on dental caries. And so he and I share articles. In fact, he just sent me another article this morning, and we share articles and back and forth like all year long, and even on other topics as well. But yeah, I was like, yeah, John, I'd be happy to do that because I'm already doing that. And I'm reviewing all these articles that are going on because I'm trying to stay abreast of just what's happening in the world of dental caries research and what can we take from those studies that can help us in terms of our clinical practice and provide better outcomes for the patients, like, what's being discovered and how do we implement that, in our practice pragmatically, right?
Well, that wraps up the first part of our conversation with Dr. Kim Kutsch. I hope you enjoyed it. One thing that really stood out to me during our time speaking together was how we have the power to challenge the way things have always been done, especially when we aren't seeing the results we know we deserve. And when we're talking about the health of the patients in our care, well, we think that is a worthy cause. And we're not done talking with Dr. Kutsch yet. Stay tuned for our next episode of Everyday Practices Dental Podcast, where we release the second part of our conversation. I have to tell you, we have a blast geeking out about the science behind improving patients' oral health. If you are serious about changing the lives of your patients for the better, you will not want to miss our next episode. Stay tuned.